All right, welcome everyone to the webinar. First, just a couple of housekeeping items. Again, my name is Steve Ports. I'm a Deputy Director of the Health Services Cost Review Commission. Several people have asked whether they'll be able to access this webinar afterwards. Some people may have to leave early. We will put the recording of this up on our website, so you or your colleagues at any time could go and play it back if you wish. We're going to hear from two individuals from CMS here in a minute, and we're going to give them plenty of time to give their presentation. At the end of the presentation, we'll have an opportunity for some questions. We ask that on your computer there next to under attendees for you to raise your hand if you wish to ask a question. We'll recognize you, and then I speak through your phone, and we should be able to all of us should be able to hear you. Who we have today, we're very fortunate to have Dr. Barbara Connors. She's the Chief Medical Officer for Region 3 of CMS in Philadelphia, along with Patrick Hamilton. He's the National MACRA Lead and Health Insurance Specialist. I was fortunate enough to meet Dr. Connors, who has been traveling around the region, helping stakeholders like yourself try to understand better MACRA, MIPS, and CPCplus. And she's been very generous in providing her time to help answer questions, help stakeholders understand what it is that's being proposed, so that stakeholders can prepare and potentially make comments. And you'll hear her solicit comments as you see necessary. Why is the HSCRC facilitating this webinar, you may ask yourself. Really, we've seen many synergies with the proposals, the federal proposals that are in place, and what the all-payer model in Maryland is attempting to achieve. And as we've said many times, success on the all-payer model is really predicated upon collaboration and working together of hospitals, physician, nursing homes, and other providers and practitioners around the state toward the same goal of improving care for patients. So we've been following what has been happening at CMS as well, and we all want to, and I believe we have a similar interest in ensuring that that our approaches this HSCRC is looking at through the all-payer model can help to optimize some of the opportunities under the MACRA and the other federal programs, particularly to help chronically ill patients. So with that, I'm going to hand it over to Dr. Connors and Patrick Hamilton.
Thanks, Steve. This is Patrick Hamilton. I'm going to step up first. I want to thank everyone for dialing in this afternoon. We have a lot of information to share with you, a lot of important information. I want to start, we have two programs that fall under the purview of the proposed rule that was released at the end of April. One is the Merit-Based Incentive Payment System, or MIPS, and the other is Advanced Alternative Payment Models, or APMs. So I'm going to give the overview on MIPS. Dr. Connors will then do the overview of APMs. We will attempt to answer questions to the extent that we can. Please keep in mind that we are under a comment period for the proposed rule. So anything that we talk about today or any comments that you make during the Q&A session or any questions that you ask will not officially be counted as comments that will be considered in the final rule process. We will tell you at the end of the presentation how you can officially submit comments. So, MACRA, with legislation that was passed last April, it was truly bipartisan. The big thing that it did, the thing that got a lot of attention in the news, was that it repealed finally the sustainable growth rate, or the SGR formula. That was the part of the fee schedule that at the end of every fiscal year, if Congress did not come together and create what we call a doc fix, then Medicare reimbursement would have been reduced by 10%, 15%, 23%, as high as 28% in some years. What it also did is replace the patchwork collection of quality programs with a single system where every Medicare physician and clinician will have the opportunity to be paid more for better care. Doctors will still be able to participate as they always have, but will have the chance to get paid more for high quality care and investments that support patients. So there are two paths in this program, and these are the two paths that I mentioned, the Merit-Based Incentive Payment System, or MIPS, or Advanced Alternative Payment Models, or APMs. And when CMS developed this rule, we were guided by the core goals of the legislation that was passed by Congress. And that is streamlining and strengthening quality-based payments for all physicians, rewarding participations in those advanced APMs that create the strongest incentives for quality and coordinated care, and also giving clinicians flexibility to choose how to participate in the new system. And when we go into details, especially with the meaningful use component, which is no longer going to be called meaningful use, we'll go into some detail as to how that flexibility is going to work. Under the proposed rule, reporting standards for MIPS and advanced APMs would be aligned wherever possible, including with commonly used measures for private payers to make it easy for clinicians to move between the different tracks of the quality payment program based on what works for them and their patients. So here on slide 3, you have the 3 reporting programs that are currently underway for Medicare clinicians. They are PQRS, Physician Quality Reporting Program, the Value-Based Payment Modifier, and Medicare EHR Incentive Program, or you may also know it as Meaningful Use. So today, the landscape is such that you have 3 different programs that you're reporting on, or that you're being incentivized or adjusted on. And what the Quality Payment Program does through the MACRA legislation is to bring these programs together. So the major provision of our proposed rule, we talk about the eligibility, who will be participating in the first couple of years of the program, and who will not be participating, including certain clinicians who will not be onboarded for 3 years into the program, and also those that will be automatically exempt from the program. The performance categories, of which there are 4, and the scoring methodologies. That gets a little complicated, but we're going to give some details about how that is going to, what we're proposing that's going to look like. Data submission in terms of how do you submit your data to CMS? Do you do it through claims? Do you do it through EHR, through registries, et cetera, et cetera? And then also the performance period and the payment adjustments. So payment adjustments, either upward or downward, will begin in 2019. The performance period will begin 2 years prior to that, 2017. So it's just around the corner. So, like I said, we're going to focus on MIPS first. Who's actually going to participate in MIPS? We are going to be referring to providers in the MIPS program as eligible clinicians. So for the first year, those clinicians that would be eligible to participate in MIPS are all physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists who bill under Medicare Part B. So when we're talking about the MIPS program, it's for reimbursement under the physician fee schedule for Part B. So Medicaid, Medicare Advantage, MA plans are not included. So that's for the first 2 years. That would mean 2019 and 2020, because those are the first years for which the adjustments would be applied. Starting in 2021, which is year 3 and beyond, we have the authority to expand those that are eligible to include occupational therapists, physical therapists, clinical social workers, dietitians, and others. So those clinicians who are not currently eligible to participate in MIPS for the first 2 years, you can voluntarily report. And the reason why you would do that reporting is to get familiar with the system, to get familiar with the nuances of the data that needs to be submitted. And if you do voluntarily report that data, you would not be held to any downward adjustments should you fall below the scoring threshold. Those who are not able to participate in MIPS, there are exceptions. There are 3 groups of exceptions. These were specifically spelled out by the legislation. First, those who are newly enrolled in Medicare Part B during the performance period. So if you are newly enrolled in 2017, and that means newly enrolled in Medicare in the PACO system, not that you are new to a specific practice, but you're new to Medicare. If you're newly enrolled in 2017, you would not be subject to MIPS in 2019, but you would be required to start reporting in 2018, the following performance period. There's also a low patient volume threshold. If you meet or exceed the proposed volume threshold, and currently that proposed low volume threshold is that your Medicare billing, and that again is to Part B, fee for service, is less than or equal to $10,000, and you provide care for less than or equal to 100 Medicare patients. You have to meet both to be excluded under MIPS for this particular exclusion. And finally, certain participants of the advanced APMs that Dr. Connors will talk about. In addition, it's very important to note that MIPS does not apply to hospitals or facilities. So if you are working in an FQHC, a federally qualified health center, a rural health clinic, a hospital, skilled nursing facility, the facilities themselves are not subject to MIPS because the facilities are not doing Part B billing. However, there could be instances where eligible providers who are working in those institutions could be subject to MIPS if they were billing outside of the facility billing methodology and billing to the Part B physician fee schedule. The next slide indicates that we know, CMS knows that for the first couple of years of the Quality Payment Program, and by the way, the Quality Payment Program, or QPP, is the collective term for MIPS and APMs. So when you hear us refer to the Quality Payment Program, or QPP, we're collectively referring to MIPS and APMs. However, they are two different paths that one can take under the Quality Payment Program. Over time, we are anticipating that more clinicians will have the capability to join advanced APMs. We're viewing now MIPS as a stepping stone for participation in an advanced APM. But as a reminder, most participants will be subject to MIPS for the first few years. So working from right to left on the slide, if you happen to be a qualifying participant in an advanced APM, and Dr. Connors will go through these details a little bit later, you would not be subject to the MIPS adjustments, and you would be getting the lump sum bonuses that are available for your participation in the advanced APM. There could be instances where you are participating in an in an alternative payment model, an APM, but it doesn't meet the criteria, the three criteria to be an advanced APM. And that's what the middle column is. So you're in a non-advanced APM. You could be getting the rewards that individual model would offer for successfully participating in that particular model. Think Shared Savings Track 1, for example. But you would still be subject to MIPS because you don't meet the threshold. The model doesn't meet the threshold for an advanced model. Or you as an individual do not meet the qualifications to be a qualified participant. You can participate in MIPS either as an individual, which our proposed definition of an individual would be a unique tax identification number, and an MPI. So the combination TIN MPI would identify you as an individual. If you have an MPI under separate TINs, then each MPI TIN combination would be responsible for meeting the requirements. And those are the same requirements we have under PQRS currently. You can also perform or participate as a group, and this is a change especially as it pertains to meaningful use. Because as you know now, as Medicare eligible professionals in meaningful use, you have to participate and submit your data as individual physicians. We are proposing to allow groups collectively as a group, and we identify a group as a group tax identification number with 2 or more NPIs reassigned to that tax identification number. And if you do choose to perform as a group, you will perform as a group across all 4 of the performance categories. Now, we do know that there is language within the MACRA law that discusses the availability of participation in MIPS as part of a work tool group or a virtual group, but that will not be ready to go into fruition in 2017, so we anticipate to have that proposed for 2018. So as I mentioned, there are 4 MIPS performance categories. And for 3 of these categories, they have programs that are already in existence that kind of mirror things or activities that we are promoting or actively looking at right now. So the first is quality, and the quality reporting would be similar to, but not exactly duplicative of, PQRS. Resource use are similar to the cost factors that we are looking at under the value-based payment modifier program. Clinical practice improvement activities, this is the new one. This is the one that does not have a program currently that we're tracking clinical practice improvement activities. We're making this, I believe, 15% of your score in the first year. There are more than 90 different activities that you have to report. You can report on as few as 3 to get full credit, depending on which activities that you pick. And then use of certified EHR technology, which we are calling now advancing care information. And this slide is an older slide, but we are now calling the EHR portion of MIPS advancing care information. So that's a new acronym that you're going to be hearing, ACI, and I'll go into probably more detail on that part of it than I will on the other ones. So just very quickly, for the first year, the quality portion, I'll just go back. The quality portion here is going to be worth 50% of your score. The cost or the resource use will be 10%. Clinical practice improvement activities will be 15%, and advancing care information will be 25%. Those put together, we will derive what is called your MIPS Composite Performance Score, which will be on a scale of 0 to 100, and I'll go into some detail as to how we actually calculate that. So our proposal for quality is that each eligible clinician would select 6 measures, which you'll note is a current decrease from what is required under PQRS. Under PQRS, currently, clinicians are required to report on 9 measures that cover at least 3 national quality strategy domains. We do not have a specific proposal that clinicians would have to choose measures that cover any number of domains. So right now, we are saying it's 6 measures. Now, we are encouraging clinicians to choose measures that span as many domains as possible. What we are requiring that of those 6 measures, 1 must be a cross-cutting measure, and an additional 1 must be an outcome measure. If an outcome measure is not available, then you would need to select from another high-priority measure. A high-priority measure is defined as an outcome measure, appropriate use measure, patient experience, patient safety, or care coordination measure. You can select from the approximately 300 measures we have proposed to be available, or we have worked with various specialty societies to create specialty-specific sets that are meaningful to you as a clinician based off of your specialty. And I believe that we have 23 specialty sets that are proposed in the rule. There are 3 additional population health measures that we automatically calculate for all clinicians. And these are the same population measures that are part of the quality component of the value-based payment modifier. That is an acute conditions composite, which includes bacterial pneumonia, urinary tract infection, and dehydration. A chronic conditions composite, which includes 4 indications or indicators of diabetes, COPD or asthma, and heart failure. And then only for groups of 10 or more clinicians, we'll be looking at an all-cause hospital readmission. Under resource use, there is no submission requirement, which means the onus is not on the clinician to report anything. This is all going to be done through administrative claims analysis. The key changes from the current value modifier is that we are going to be looking at two specific measures: a total per capita cost for all beneficiaries for Part A and B, and a Medicare spending per beneficiary. Currently, under the cost component of the value modifier, we're looking at total per capita cost for 4 specific conditions. And in the proposed rule, the discussion was that not all clinicians can be equally or adequately rated or assessed based on the 4 conditions that are currently part of the value modifier. So instead of mandating that everyone is assessed on those 4 specific conditions, those are being COPD, congestive heart failure, coronary artery disease, and diabetes. We are adding more than 40 episode-specific measures that address specialty concerns. So that means that if you are an allergist, for example, COPD may not, for whatever reason, pertain to your practice, but we do have episode-specific measures that do pertain to your practice that are more adequate and more meaningful. So that is for the resource use or for cost. For the clinical improvement, the clinical practice improvement activity, our proposal is that clinicians would have to do at least one activity from a proposed set of 90 or more activities. You get a score, you get any score for doing at least one activity. The activities that are in the list of activities, and I believe that there are more than 90, there are 90 or more proposed activities. Some are worth 20 points if they have been deemed a high priority, and the rest are worth 10 points if they've been deemed a medium priority. So the maximum number of points that you can get for the clinical practice improvement activity is 60 points, which means if you get 60 points, you get that full 15%. So in order to get any points, in order to get any score, you have to pick at least one activity. But if you do 3 high priority activities, that's 3 times 20 points. You can get your 60 points that way. If you want to do 6 medium activities, that's 6 times 10 points. You get 60 points that way, or any combination thereof. If you are participating in a patient-centered medical home, you automatically get the full credit. You get the full 60 points. If you're in an alternative payment model, even if it's not an advanced APM, you automatically get 30 points, and then you just try to pick the activities. They'll get you the other 30 to get full credit. And again, this is 15% of your score in the first year. Moving on to the next slide, we're talking about advancing care information. Now, this one's going to be a little trickier in that we would say that all MIPS eligible clinicians can participate as an individual or a group. But those that we are proposing would not be eligible for the first year would be nurse practitioners, physician assistants, the certified registered nurse anesthetist, and clinical nurse specialists as individuals. Also, hospitals and Medicaid are also excluded from advancing care information. The reason why the 4 non-physician practitioners that I mentioned are excluded is because they, up until this point, were never eligible for Medicare meaningful use. So it's very possible that those 4 non-physician practitioner types or clinicians may not have a system in place. They may not be familiar with the objectives and the measures. So what we are proposing for the first year, that the NPs, PAs, CNSs, and CRNAs would not be able to participate, or would be ineligible to participate. They would use 2017 to get on board and to be ready to participate in 2018. Also, we note that if you are participating in Medicaid meaningful use, but you are an eligible clinician for ACI, your Medicaid meaningful use will not count towards your ACI participation and vice versa. So it's very important to keep in mind. So again, going from right to left, a full 25 points or 25% is what you are striving for the first year under ACI. There are 3 main categories or 3 main areas for the ACI category, and they're listed here, that make up the ability to get the full 25 points. And I know that this is going to be kind of confusing without going into a full explanation of how you can get the points and trying to map it out and make it look nice, but I just want to give you at least a basic understanding of what we're proposing. You can get a base score of 50 points, a performance score of 80 points, and 1 bonus point. So if you add 50 plus 80 plus 1, you get 131. However, you only have to get 100 of those 131 points in order to get the full 25%. So when I discuss how, especially that performance point, that performance score piece, there's going to be multiple pathways for you to get full credit for ACI. The big takeaway for ACI is that it is no longer an all or nothing program. Currently, Medicare meaningful use, if you miss one objective, if you miss one threshold, you fail meaningful use and you get the penalty. That's not the case with ACI, or it's not the case with the MIPS composite score altogether. Now, you will be able to get a higher score if you have higher thresholds. But those percentages that you had to meet currently under the Medicare program, they are going away. So for the base score, for 50 points, clinicians must simply provide the numerator or denominator for at least one patient for the 6 objectives and the associated measures that require numerator or denominator, or a yes or no for each of the objectives or measures. There are 2 that require a simple yes or no. Now, one thing to note, if there is no security risk analysis, if you do not do, because we put such a focus on maintaining the safety of patient records, if there is no security risk analysis, which is the first objective, then you get a 0 for the base score and you can't get any performance score points. So not doing the security risk analysis under the proposal would mean a 0 for ACI altogether. These are the 6 objectives that require for the reporting for the database. So it's protecting patient health information, which is what I just mentioned, coordination of care through patient engagement, and that includes the view, download, transmit measure, the secure messaging, and a new one, patient-generated health data, electronic prescribing, which is self-explanatory, patient electronic access, which is patient access and also patient-specific education, which is currently part of the program, health information exchange, so that's patient care record exchange, requesting or accepting patient care records, and clinical information reconciliation, and the public health and clinical data registry reporting. Now, a yes is required for immunization. And this is another one that if we do not get a yes, then you get a 0. However, there will be some exceptions for those clinicians that do not do immunizations. However, with the protecting patient information, there are no exceptions. But we know that there's going to be some instances in which certain clinicians are not going to be doing immunizations. So that's the base score. The performance score is looking at these 3 objectives, 3 of the 6 objectives that are part of the performance score. Now, as I mentioned, with patient electronic access, that's patient access and patient-specific education. The coordination of care is the view, download, transmit, secure messaging, and the patient-generated health data. And the health information exchange is the patient care record exchange, the request or accept patient care record, and clinical information reconciliation. So under these 3 objectives, there are a total of 8 measures. Your performance in each of these 8 measures could be worth a maximum of 10 points each. So obviously 10 times 80, that's where we get the 80 points. How you get those 10 points, it's simply conversion of the percentage of patients or the percentage of activities that you report. So for example, if 90% of your patients get patient access, then they get 9.0% of the patient access measure, so you get 9 points. If 95% of you were able to report a threshold of 95% of clinical information reconciliation, then you get 9.5 points for that measure. So you're probably thinking, well, view, download, transmit. Those are the ones that we've been having trouble with. Secure messaging, the threshold was 5%. You may be thinking, if I want to get 5 points, I have to have 50% of my patients do secure messaging. And we know that that's probably not going to happen right away. So even if you are lower on some of the percentages, you still have ample opportunity to report higher percentages with some of the other measures to max out on those additional 50 points that you need to get 100. You get that extra point if you report on more than one of the clinical data registries. So if you report to something in addition to the immunization, you can get 1 extra point. So remember that one of the principles we have for advancing care information, and really all the categories under MIPS, is to allow for flexible scoring. So again, as I mentioned, we dropped the all or nothing threshold for measurement. And we've also removed some of the redundant measures to alleviate reporting burdens. And we did that in our proposal for the Stage 2 realignment that we put out last year. So the composite performance score. So I talked about all 4 pieces of the composite, the categories that we're looking at. So now, how do we come up with your actual composite score? At a high level, the proposed MIPS CPS method accounts for the weights of each performance categories. That's why I told you quality was 50%, ACI was 25%, et cetera, et cetera. Exceptional performance factors. I didn't go into detail in the quality reporting, but there is opportunities to get bonus points in the quality reporting section as well. Availability and applicability of all measures and activities for different types of clinicians for each of the categories, and some of the special circumstances that small or solo practitioners face, practices that are in rural areas, underserved areas, and non-patient-facing eligible clinicians. A couple things to note related to our overall approach to scoring the CPS under MIPS. First, we've converted all the measures and activities to points based off of decile break marks, which is based on a 1 to 10 historical benchmark, if a benchmark is available. Second, we feel that it's very important clinicians know what the benchmarks are and what the overall MIPS performance threshold is prior to the beginning of the performance period. And finally, we feel it is important to provide partial credit where information and data is available. So for all of these categories, we've taken an all or none approach. We've not taken an all or nothing approach. Rather, we will provide percentage points based off of the data we've received and that we can calculate. The next 2 slides tells how you can report data for each of the performance categories. So basically, the main reporting mechanisms are claims, qualified registries, qualified clinical data registries or QCDRs, an EH vendor or your EH system, administrative claims, and that really is only for some of the quality measures and also for the cost measures. The CAPS for MIPS survey, which is available for groups for certain quality measures, and also the web interface, which is available for groups of 25 or more. So if you go through those 2 slides, you can see how you can submit your data for each of the categories. We do allow an individual or for a group to use more than one mechanism or more than one reporting method for each of the categories, but you can only use one mechanism for each category. So for example, you can use claims for the quality reporting, you can use attestation for the ACI, you can use qualified registry for CPIA, for example. However, you can't use claims in a registry for quality. I mentioned the MIPS performance period. The payment year or the adjustments start in 2019. So the first performance period is 2017. It's the 2-year look-back period that has been part of our programs in existence for the past couple of years. A composite score or a CPS that falls at or above the threshold will yield a payment adjustment of 0 to 12% based on the degree to which the CPS exceeds the threshold. And in addition to that, if you are truly exceptional, there is a certain pot of money that's been set aside by Congress not to exceed a 10% bonus if your scores fall a certain number, I believe, of standard deviations above the threshold, the general threshold. And then any scores that fall below the threshold, to the degree that they fall below the threshold, there will be a downward payment adjustment. The downward payment adjustments start at 4% in 2019, and they increase to 9% in 2022. I would note that the 4% payment adjustment right now in 2019 is lower than the combined payment adjustment that you could be receiving this year or next year for failure to do PQRS value modifier or meaningful use. I believe the combined downward adjustment, if the programs we're staying currently could go up to as high as 12% by next year. So these payment adjustments, downward payment adjustments, are lower than what would have been in effect if this legislation had not been passed. And then again, those upward adjustments could be multiplied by a factor of 3 each year with an additional 10% for truly exceptional performance. And that's what this slide will indicate here. And then my last slide basically tells you how the payment adjustments will work. If you fall below a threshold, you do not automatically get the lowest amount of adjustment. If you are in the lowest 25% of scores, then you will automatically get the maximum reduction, which is the 4% you see here. But if you fall slightly lower than the threshold, then the payment adjustments could be slightly lower. So that is MIPS in a nutshell. I know that I gave you a lot of information, and believe me, we just scratched the surface. After the rule has been finalized in the fall, we will be going into much, much more greater detail so that you'll have all the information that you need in order to be successful with the program. So now I'm going to turn over to Dr. Connors, and she is going to talk about advanced alternative payment models.
Thank you, Patrick. Great presentation. So what is an alternate payment model, an APM? And I apologize for all the acronyms. I know sometimes the groups that I speak with, their head is spinning. So I'm referring to an alternate payment model at this moment, APM. It is defined in MACRA, and it includes a CMMI Innovation Center model under a Healthcare Innovation Award, a Medicare Shared Savings Program, a demonstration under the Healthcare Quality Demonstration Program, or another demonstration as required by law. But AAPM, Advanced Alternate Payment Models, must meet certain criteria to fulfill your requirements under this proposed rule. So let's talk a little bit more about medical home model as well as the other requirements. They must meet certain criteria. As defined by MACRA, they must, it requires that participants use certified EHR technology. The APM bases quality on payment measures comparable to those quality measures in MIPS. It does not have to be the identical measures, but it must be comparable. And the APM either requires the APM entities to bear more than a nominal financial risk for monetary losses, or is a medical home model expanded under CMMI authority. Now, before I go any further, I'd like to point out that CMS believes that the vast majority of clinicians will fall under MIPS, the discussion that Patrick just gave. So I don't want you to get really upset or worried or excited over the notion of going into an AAPM. For those of you that are already in APMs, you're probably well on your way, but for others, just keep an open mind. Think about how your practice would fit into a model like this, because at the end, I'll tell you how you can actually participate in the formation of future models based on your experience and the kind of practice that you do have. So let's talk a little bit about medical home. The term medical home comes up in a few different places throughout the rule, so it's important to keep this concept in mind. On the left, the blue box reflects the medical home model features as we propose to define them. First, participants include primary care practices or multi-specialty practices that include primary care physicians and practitioners and offer primary care services. Second, There's an empanelment of each patient to a primary care clinician. And finally, the model must meet any 4 of the 7 subsequent points on the right. I won't read it to you, but they must meet at least 4 of those criteria in order to meet the criteria for a medical home. So as I said earlier, an AAPM, an advanced APM, requires the use of certified electronic technology. At least 50% of the eligible clinicians must use certified EHR technology, with that percentage increasing in subsequent years after the first year. Remember, we want to make sure clinicians can move in and out of APM seamlessly without having to run into issues about having different types of technology requirements. So then when we say certified EHR technology here, it means the same as advancing care context. And systems are beginning to mature, so this should be a fairly seamless move from model back to MIPS to another type of AAPM if that clinician chooses to move. For the shared savings program only, the standard is that the APM may apply a penalty or reward to APM entities based on the degree of certified EHR technology use among the clinicians. This fits within existing structure so that certified EHR technology use actually factors into the amount of shared savings or losses ACOs can receive under the shared saving program. That element of shared savings program would meet this requirement. The second criterion is MIPS comparable quality measures. An advanced APM must base payment on quality measures comparable to those under MIPS, and there's no minimum number of measures or domain requirements. However, there must be at least one outcome measure under the advanced APM unless there's not an adequate outcome measure at the time the advanced APM is developed under MIPS. So what does comparable mean? It means any actual MIPS measures or other measures that are evidence-based, reliable, and valid. And examples of those are listed here, but it's not exhausted list by any means. Now this is where it gets a little dicey for the average individual, so bear with us. And again, this is in the proposed rule. If you're considering going into an AAPM, you may want to have your CFO or your financial person look at this in the context of your business and whether this would be an endeavor that you are actually ready to take on. So the third criteria requires APM entities bear more than a nominal risk financially. And this is the most complicated of the 3 criterion. So we're going to walk through several slides on this concept. Within the nominal financial risk criteria, there's 2 standards which must be met. That is a financial risk and a nominal amount. The financial risk standards determines whether there is financial risk for monetary losses under the APM. The nominal amount standard determines whether the amount of that risk is of sufficient magnitude to meet the nominal amount standard. Now, there are a few things to point to related specifically to medical homes, and they're a little different. The first is that this whole criterion is completely met if the APM is a medical home model expanded under CMS Innovation Center Authority. And secondly, we recognize that pre-expansion medical home models and participants are unique, so we're proposing slightly different financial risk, and nominal amount standards for those particular medical home models. So let's go back to the generally acceptable standards here, and we'll get to the medical home model versions next. This is determining whether or not the model is requiring the APM entity to bear risk. On the left in the blue box, you see the trigger for what causes risk to be borne. On the right in the green box is what kinds of arrangements would be considered risk. And these include direct payment from the APM entity, or a reduction in payment rates to the APM entity or eligible clinicians, or withholding of payment to the APM entity or eligible clinicians. Now for medical home, it's a little different. The amount of risk under a medical home model would be lower. It would be 2.5% of Medicare Parts A and B revenue in 2017, as opposed to 4% in the other AAPMs. And as you can see, in subsequent years, it does move up, but for the first 2 years of medical home, the amount of risk is less. The other criteria for medical home for the nominal amount standard is subject to size limitation. The medical home model standards only apply to APM entities with less than 50% eligible clinicians in the APM entity's parent organization. Now, the rule itself specifically identified AAPMs that meet the criteria for being AAPMs, and that is Shared Savings Program Track 2 and 3, the Next Generation ACO Model, Comprehensive ESRD, which is, at this point, large dialysis organization arrangements, Comprehensive Primary Care Plus, and the Oncology Care Model, which will be a two-sided risk track available in 2018. Those in the OCMs for 2017, however, will not be considered in an AAPM, and those providers will be, or those clinicians will be required to participate in MIPS. So how do you become a qualifying APM participant? You must have a certain percentage of your patients or payments through an AAPM. In the proposed rule, the determination of whether an entity is an AAPM is made at the entity level. So if you are in an AAPM, that determination is made at the entity level. So if you are in that AAPM, then you are considered, if you are in that entity, then you are considered in that AAPM. However, there's a caveat here. And I'm bringing up something that was sent to me earlier that I want to make sure that we have some time for discussion. And that is those clinicians that are in CPCplus. A CPCplus is considered an AAPM. However, not all clinicians in a CPCplus are considered eligible to be in the Comprehensive Primary Care Plus as an AAPM. Now, I realize that's clear as mud, so let me go into a quick definition. In order to be eligible to be in a Comprehensive Primary Care Plus, you must be either a general internist, family practice, a geriatrician, or general medicine. You could be one of those four and in a practice with specialists. Only those four practitioner types are considered in the CPCplus, even if other specialists are billing under the TIN. So if you're a specialist and your colleagues under the same TIN are one of those four and in the CPCplus, you are not part of that CPCplus. So I wanted to get that out of the way so we had time. So let's go back to eligible clinicians becoming qualified professionals or qualified practitioners in an AAPM. The period of assessment is the same as the MIPS performance period. And it's a full 2 calendar years prior to the payment year. So first off, you cannot become an AAPM in 2019 and assume that you're covered for 2017. As Patrick showed earlier, your performance year, in this case, again, is 2-year look back. So if you're in an AAPM in 2017, your payment in 2019 will be based on your performance in 2017. However, if you're in an APM, such as a Track 1 ACO, you still have to participate in MIPS. You can move into the AAPM, and in subsequent years, your pay would be based on that. So we calculate a threshold score for each advanced APM entity, and we use 2 methods to do that. That is the payment amount and the patient count, and they're both based on attribution under the particular APM. The general idea is that the numerator is looking at beneficiaries who are attributed to the APM entity through whatever terms that APM uses to do attribution, and the denominator is attribution eligible. And this is very similar to how we calculate the MSSP attribution. So this next slide shows 2 different methods that we use, and we'll calculate a threshold score under both of these for each APM entity and take the one that results in a more favorable qualified professional status. On the left, we have the payment amount method, which uses all the dollars for Part B professional services in the numerator that are attributed to beneficiaries, and the same types of services to attribution eligible beneficiaries in the denominator. And on the right, you have the patient count method, which is similar, but the number of attributed beneficiaries divided by the number of attributable eligible beneficiaries. And then finally, we take the threshold scores that we've calculated for that AAPM and compare it to the thresholds themselves. If the threshold score is above the relevant threshold in the table, then the APM would meet the QP status. The table on the left reflects the payment amount QP thresholds as set forth in statute. And on the right, the table reflects the patient count thresholds that we are proposing. Now, what if you're already engaged with private payers or Medicaid APMs? Can they help me qualify? Well, not next year, but in 2021, certain private payer or Medicaid APMs can count towards the criteria to be a QP. These payment models must meet certain requirements that are similar to the requirements to be an AAPM. These include having certain quality measures, bearing more than nominal financial risk, and using certified electronic health record technology. And this is formally known as the combination all-payer and Medicare threshold option. The last step of the incentives for AAPM is how we actually do the calculations for the incentives and what QPs receive by virtue of being a QP. It is based on the estimated aggregate payment for professional services under Medicare Part B services furnished in the year prior to the payment year. So let's walk through that. In 2017 is your performance year. We look at 2018 Part B professional services, and if we take 5% of that and send it to you in 2019 in a lump sum payment. And this slide basically reiterates what I just said, and the cycle continues if you remain in that AAPM. So this slide basically combines the MIPS and the advanced APM. The rules set aside money for the 5% bonuses through 2024. And as you are aware, the MACRA also includes physician fee service increase of 0.5% for the next 4 years, including 2016 through 2019. There's no change in the fee service between 2020 and 2025. Beginning in 2026 and onward, if you're still participating in MIPS, you receive a 0.25% physician fee service increase. If you are in an AAPM, it's 0.75%. That 5% bonus is gone. Also keep in mind that if you are in an AAPM, you're also receiving the other monies from shared savings. So this slide essentially puts it all together for you. So what about those who are in APMs, the ones that meet the criteria? They, all the way on the right, they as I just said, they receive the APM-specific rewards, the 5% lump sum bonus that ends after 5 years. But if you are in an APM, if you're in the middle column, you can receive your MIPS adjustments. That would be upward, neutral, and in addition, your APM-specific rewards. It's doubtful that you would receive APM-specific rewards and a downward MIPS adjustment. So if you feel that at some point you want to move into an AAPM, I recommend you first get involved in an APM unless you are specifically in one of those models listed in MACRA where you're automatically considered. MACRA also set aside $20 million, and that money is going to go to 2 areas. One is to help small practices to provide technical assistance regarding MIPS performance criteria. Now, we put out an RFI in March. We haven't given out any contracts yet, so I can't give you any more information on that. Additionally, for small practice or large practice or specialty practice, there is the TCPI program where you can work with a PTN to help ready your practice towards ultimately participating successfully in an AAPM. The $20 million also sets aside monies for the PTAC, the Physician-Focused Payment Model Committee. The committee has met twice. It has not yet received any recommendations from physicians regarding physician payment models. This is what I referenced early on in the context of the PTAC is going to look at recommendations from different physician groups or individuals that are recommending to the committee what would be a good physician-focused model. The oncology care model, which is essentially the first specialty patient-centered medical home, would be something that you might want to look at in the context of how a physician-focused model has been developed by CMMI. 3 criteria for a physician-focused model: payment incentives for higher value care, care delivery improvements. It's all starting to sound the same. All of the different programs have essentially the same criteria, and information availability and enhancements. This is the PTN that I referenced, Practice Transformation and Action Network. We have 29 PTNs that are ready and available and out there recruiting practices. This is of no cost to the practice. If you think you might need some help and just avail yourself of this service, they'll come in and they'll work with your staff, they'll look at your records, they'll look at how you're using EMR, they'll help you with good business practices, and they're working with SANs such as the American College of Physicians, American College of Radiology, who have developed standards for the PTN to incorporate into your practices. And these are your benefits to participating clinicians: optimizing health outcomes, promoting connectedness of care for your patients, learning from high performers how to effectively manage patients and families, more time spent caring for your patients because your records and your office is better organized, stronger alignment with new and emerging federal policies, and an opportunity to be a part of the national leadership in practice transformation efforts. And this is really important for Maryland clinicians in the context of how you've already moved away from the traditional hospital model. You might want to work with the PTNs that have come down into Maryland that have really been looking at the differences in practice patterns in Maryland and how they can help you move towards either being initially successful in MIPS and ultimately successful in an AAPM. These are the PTNs that are currently coming into Maryland to work with the clinicians. And as Patrick referenced early on in the presentation, this slide tells you where you can send comments on the proposed rule. You have till 5 p.m. EST, Eastern Standard Time, June 27th, to submit the comment. And the importance of doing that is we're required to look at every comment. Your comments help form the final rule, and we want to hear from you because this really has to do with how the future of these models and quality reporting and payment reforms will move to. I think we have time for questions.
Yep.
Oh, okay, so we have
20 minutes.
We have time for questions.
All right, we're going to get set up here. Thank you very much, Dr. Connors and Patrick.
So while we're looking at other audience, this is Shula Gerovich from HSCRC. I had a question about the MIPS. You mentioned the bottom 25 will get the maximum penalty. Is that a relative ranking? So at the end of the year, you're going to calculate total points and then look at the bottom 25, or is there some threshold that you're going to publish ahead of time?
There's going to be a threshold that CMS will publish. There will be an overall threshold for the composite score. There will also be thresholds that will be published based on benchmark data in those areas where we have benchmark data ahead of time. So when I was mentioning the 4 different components of your score, that's from 0 to 100 before the performance year, or before the performance year, CMS will say, here is where the threshold is for on the scale of 0 to 100. And then how you fall either above or below that threshold score will determine the extent of your upward or downward adjustments. So for example, if the threshold is 50%, and let's see, if you're in the bottom 25%, I think that would be 12.5%. I think is the bottom, would be the bottom fourth, I think. I don't have a calculator in front of me. That's who would be getting the maximum 4%. Let's just say the 12.5% is the bottom 25%. I think it is, but if it's not. But if it is 12.5%, if you're between 12.5% and 50%, then your downward adjustment would fluctuate. It would not be the maximum. And then conversely, it would work the same way for the upward adjustments.
And if you're at the highest, then you could go to the 3 times the amount.
Right.
Next question will be Miriam Solden. And again, if somebody wants to get in the queue for a question, please raise your hand. Miriam, go ahead. We don't hear you. I think you just self-muted. Here. All right, we'll try Anurada Reddy. Go ahead.
Can we access this slide? That's my question.
Say that again.
Can we look at the slides on the websites anywhere?
Oh, I would ask Dr. Connors, do you have this available on your website, the slides?
Yes. In fact, this is an abridged copy. I believe the full slide deck is 96 slides. Slides are available, and we still have a series of webinars coming up into, I believe, the second week of June, if you want to listen to this again.
Or else what we can do, Steve, we can coordinate this through you, because we put some additional information on TCPI at the end, which isn't in the slide deck. We can convert this to PDF and send it to you, and then you can send it out to the participants if you can do that.
All right, that'd be great.
All right.
Yeah, at least for the participant, because we already went through the webinar, so we can have, if you want to look back and review, we can have the slides.
Sure.
We can't take written questions right now, so if you want to ask a question, please raise your hand and we'll open your mic. Okay. Donna Kinzer. Go ahead, Donna.
Hi. I wanted to ask you if you could go over the numerator and denominator calculations once again and give an example.
Is that for the MIPS or the AAPM?
For the AAPM.
Okay. Can we pull the slides
Give me just 1 second.
Appreciate it.
Now keep in mind the numerator denominator would be specific to that AAPM.
Right, so it's saying the numerator is the
attributed beneficiaries, for example, for cost and quality of care. And then the denominator would be the attribution eligible beneficiaries who could potentially be in that AAPM. So let's use the example of
let me use an ACO as an example, so I can just kind of understand. So let's say we have an ACO and it has a certain number of primary care doctors in it.
yes.
Those primary care doctors beneficiaries are all attributed. So those are the primary care doctors beneficiaries, and there are some specialists that are also participating in it. But of course, they don't have any
attributable eligible. Well, the primary care practitioners in that ACO have attributed beneficiaries, but they do have other beneficiaries that are not attributed to them, because there's a cap on the number of beneficiaries that are attributed to that ACO. It's not every primary care, it's not every eligible beneficiaries that is actually attributed. In past years, they populated at the end. Now, the ACOs, it's pre-populated, so the practitioner knows the attributed beneficiaries. But there are still many more beneficiaries, perhaps, depending on the size of the ACO. So the denominator would be those attributed eligible beneficiaries.
Right, but how would a specialist, so if there's a specialist in this model, maybe those particular primary care doctors only contribute 5% of the work of that particular practice for Medicare, or 10% or 20%, but not some high percentage of that specialist. So how does the specialist participate through this model? Through an ACO model, do they automatically qualify based on the primary care numerator and denominator? I don't understand how this relates to a
well, you're comparing apples and oranges now, because only certain ACOs where there is specific financial risk, only certain ACOs are eligible under this program. You bring up a very good question. If there are specialists in that ACO, what is the attributable eligible beneficiaries? And honestly, it's a good question. I don't have an answer, but I would expect that within that ACO, let's use cardiology as an example. The cardiologist would have some attributed beneficiaries to his or her practice within that ACO. Additionally, there would be other cardiology patients that that cardiologist cared for that isn't counted in. What the percentage of the total of the patients within the ACO, I don't know, but according to the proposed rule, the eligible clinicians become QPs by the threshold score for each entity. So it's a good question, but I have not been asked this question before, so I'm kind of thinking out loud. I would assume that if there is a specialist within that ACO, they would be considered a QP in that ACO because it's paid at the entity level.
Based on the primary care formula.
Primary care, but you know, again, you bring up a really good question. It's possible and probable, since your next gen and your pioneer ACOs, they have more specialists than the other ACOs, the MSSPs. It's possible that they're going to have their own attribution. Send me an email. Are you in an ACO now?
No.
Okay. I mean, it's a good question. Why don't you send an email to me, and I will check with I'm going to have to go to the ACO and the MACRA folks, because this is why it's so important for clinicians to comment on this proposed rule, because you're come up with nuances that could impact your practice that we might not have thought about. So my email address is Barbara, BARBARA.Connors, CONNORS @cms.hhs.gov.
Okay, next question, James York, your mic is open.
Yes, thank you very much for this very detailed presentation today. My question is, can hospital-employed specialists get involved in advanced payment models either separately from the hospital entity or in a purely specialty-driven entity underneath the hospital corporation? So, for example, ENT or orthopedics or neurosurgery has a lot of care and procedures that don't necessarily come under the referral patterns and oversight of primary care. And so often the risks that they have, their RVUs per member per month or something like that, is actually calculated separately and has sort of a weak overlapping risk, but is actually often separate. People even like in orthopedics have talked about an orthopedic home, because there's so much of what we do that's primary care musculoskeletal.
Are you an orthopedist?
Yes.
Okay. Thank you for that excellent question. The Learning in Action Network has been looking at exactly what you are describing. And in fact, they've been formulating what is a orthopedic clinical episode of care. What are the components in an orthopedic clinical episode of care? You may want to go onto our Learning in Action Network, get involved. They're looking for input from orthopedists. Having said that, you're describing a specialty medical home, tantamount to the oncology care model that we now have up and running. The PTAC is exactly, the purpose of the PTAC is exactly what you just described. For us to hear from specialists that are all too often marginalized by these quality reporting programs. What comes to mind is the PQRS for several years, PQRI, PVRP at the beginning. We've had very, very primary care-centric kind of measures, MSSPs, primary care-centric, and so the PTAC specifically is designed to hear from clinicians such as yourself to help develop exactly the kinds of models that you're describing. And I agree. Neurosurgery, another specialty in and of itself, the referral patterns, the care management of those patients. And that's why we have the PTAC. And finally, I suggest you look at the CJR model. I'm not sure if you're familiar with that, being in Maryland, but the...
I am familiar with it, yes.
Okay, so although that's really a hospital-centric model, it gives you a sense of orthopedic is an episode of care. It's just, that the Part B payments remain unchanged at this point. Whether ultimately, after we test this for a few years, we change that, I don't know. But again, thank you for your very thoughtful comments. And I really, if you wrote down my email address, please send me a note, and I'll connect you with the folks at the Learning in Action Network.
Thank you.
You're welcome.
Nicole Stallings, I see you had a written question. I've opened your mic.
Thank you. Two questions. One, the question earlier regarding specialists participating in ACOs, where you're going to consider that, how would that answer be shared with the folks that are listening to this webinar? And then the second question is back on CPCplus. Can you confirm, please, that group practices in any track of MSSP are eligible to participate in CPCplus? Thank you.
I'll work with Steve Port. Steve, if you want to share the answer, you can. I'm assuming you have the email addresses of all the participants on today's webinar.
Yes.
Okay.
And on the CPCplus?
On the CPCplus, a couple points to the CPCplus. The MSSP participation, I believe that for the CPCplus, the ACOs, the Innovation Center ACO models, you can participate in both the MSSP and the ACO. Keep in mind the MSSP track 1 really isn't a risk model. So the one caveat for the participating in both is that if you're in an MSSP and you're in the CPCplus, I believe you forego the fee for the per member per month payment. And I also believe that if you're in the bundled payment model 2, model 3, you can also participate in the CPC2. There was another question that came to me earlier on the CPCplus. Apparently, there is some misunderstanding that if a specialist is in a practice that is considered CPCplus, that they have satisfied their AAPM status under MACRA, and that is not true. And that is simply because, as I said earlier, you must be one of those 4 primary care category listed in the application to be in CPCplus.
Thank you. And one follow-up, if I can, related to CPCplus. Will the fraud and abuse waivers that go along with Next Generation ACO and Track 2 and 3 MSSP also follow for participants in the CPCplus initiative?
Well, you're comparing apples and oranges because the Stark rule applies to the hospital. A CPCplus applicant is a practice. So you can have a TIN that is part of a healthcare organization applying for CPCplus, but it is the practice entity, not the hospital entity. Does that make sense?
It does. I'm thinking more about the role of the ACO entity and how that works, but I want to think about that one some more. Thank you very much.
Okay, so the role of the ACO entity, that would be the hospital. You're talking about the hospital now, and again, the ACO entity for the hospital is immune from any Stark rule regarding providing computers or even patient referrals, et cetera, et cetera. But the entity that would be applying to be in the CPCplus is the practice. If you look at the application, it's the practice. However, if you're an ACO, you're not going to be applying to be the CPCplus.
Right.
Okay? The ACOs cannot apply to be part of a CPCplus. Okay? You can't be an ACO and apply to be a CPCplus. If you're a provider in a CPCplus and your practice is in the ACO, you should be okay, but you can't be an ACO entity applying to be a CPCplus. So then the Stark rule really is moot for that ACO, and again, for the practices, it's different because it's that entity.
All right, next question. Hugh Dawkins, you had a written question. I've opened your mic.
I'm just really concerned in trying to find a resource for primary care practice to get assistance with meeting these new requirements in Maryland.
Okay. Where are you located?
In Maryland.
Where in Maryland? I'm sorry.
Where? On the Eastern Shore?
Okay. Could you send me an email and I will link you in with the PTNs?
Sure.
Send me an email tomorrow. Give me a sense of the size of your practice. I don't want to select a PTN for you, but just give me a little bit of information.
Okay. Yeah.
Okay. BARBARA.Connors, CONNORS, @cms.hhs.gov. And I really suggest that anyone on the call that thinks that they really want to avail themselves, Congress appropriated money, MMI, for us to go out and give this technical help to practices through CMMI. So please take advantage of it. There's no strings attached.
I will send you an email tomorrow because it's a practice in flux, so we need some help.
Yes, yes.
Okay, Dr. Patricia Zapp, you had asked a question. I've opened your mic.
Sure, it's another ACO question, sorry. So Track 1 ACOs do not qualify as an advanced APM per the proposed rule. Are you aware whether the MSSP will allow Track 1 ACOs to convert to Track 2 or 3 or even the next gen models midstream in their 3-year commitments?
Excellent question. And if you are in an MSSP Track 1 and you think that you would be ready to choose an option if it were available to go into Track 2 or Track 3, please send a comment. You know, some of this, when the MSSP was passed last year, the final rule, we didn't have this information, so things do change. And I'm sure you're not the only MSSP Track 1 that is considering this. Keep in mind, though, that you're going to have to participate in MIPS next year.
Yes.
Okay, I think that we've...
And we've exhausted all the questions, so I think that's about it, and our time's up. So as Dr. Connor said, feel free to email her if you have any further questions. We will put the slides up on our website, on the HSCRC website. I hope this was informative, help everybody to move forward. I know it's helped our staff as we're trying to take advantage of some of the synergies of the hospital program and the what's happening nationally. So once again, thank you very much, and we look forward to working with you in one way or another. Thanks.
Thank you.